morning. Welcome to the Health Beyond Research and Innovation Showcase for the BestSTART-SW Sydney Academic Unit. My name is Professor Valsa. I am the Chair of Infant Child and Psychiatry at UNSW and also the head of the Clinical Academic Unit and of Director of BestSTART here at South Sydney LHD and Institute. It's indeed my great pleasure to invite Mr. Rob Doyle to deliver the acknowledgement to the country.
Thank you so much, Professor. And as you can see, I'm wearing the same shirt in the picture, just so everyone definitely knows it's me. So yeah, my name's Robert Doyle. I'm named for my granddad. I'm an Aboriginal man brought up on Darkinjung country. My heritage is Katagaliora on my mum's side. And on her father's side, it's Winninini, which is a very small known community from the Northern Territory. I'm speaking to you from Dudawal land and acknowledge the elders of the community here who are tireless in their efforts to protect community and strengthen our kids, and also acknowledge that this broadcast is being hosted on Darug land, and recognize that we're all sort of coming in and tuning in from various parts of the country, and just acknowledge that we're all part of the Koori community in this area too. I just want to say briefly as well. It's a little bit of a scary time for Aboriginal people. We're looking at having the voice in Parliament, and any time there's a big change in the government for us, things start to heat up a little bit. Identity starts to get challenged. People start to get a bit aggressive and hostile sometimes. And I just invite you to consider, as you think about what it means to acknowledge elders and what it means to respect land. What might that look like to you, and what are we doing to support the voices of Aboriginal leadership? So that was it. Welcome everyone, and I hope you have a good meeting and get a lot out of it. Thank you.
Thank you very much indeed, Mr. Rob Doyle, for that excellent welcome to the country. And it is my great pleasure now to introduce Professor Les Bouquet. Among the many hats, the two relevant for today are he's the Director of Research at the Ingham Institute and also at the South Sydney Health District. Professor Bouquet.
Thank you very much, Valsa. And thank you, Robert, for reminding us of the importance of reflecting and acknowledging the traditional custodians of the lands on which we are meeting. Thank you very much for doing that so eloquently and elegantly. In my role as Director of Research for Southwestern Sydney LHD and the Director of the Ingham Institute for Applied Medical Research, it is my absolute pleasure to welcome our guests, Associate Professor Elizabeth Murphy. Thank you for being with us, Elizabeth. Professor Raghu Lingam, Professor Paul Middleton, Sue Wolfenden, and the many other contributors to this symposium. It's my pleasure to introduce the BestSTART Showcase for 2022. BestSTART is a unique program which has been led by Valsa Epen, Raghu Lingam, and many others. The research has attracted both local, national, and indeed global attention. Valsa and her colleagues, a multidisciplinary team, have shown that barriers to optimal learning capacity can be identified before a child starts school. Early investment in the intellectual capacity of a child leads to long-term benefits for both the child and the community at large. Hence the importance of BestSTART. It is also my pleasure to announce today another multidisciplinary initiative of Southwestern Sydney LHD, which aims to improve child health. SWITCH, which stands for Southwestern Institute for Translational Child Health, is a multidisciplinary plan to address child health and well-being, spanning from preconception to early adulthood. This team of pediatricians, allied health colleagues, nursing, community and population health colleagues will bring together the many facets that determine a child's well-being and progress into adulthood. By addressing health at an early stage, the community at large will benefit from early detection and prevention of factors which contribute to well-being and to ill health. Southwestern Sydney LHD has established its credentials as a strong supporter of research. The LHD, quite uniquely, has funded several academic units to promote translational research for the benefit of our community and beyond. The research of one of the academic units, led by Professor Valsa Epen, has more than vindicated the LHD's investment in research. Valsa and her team have been acknowledged internationally for their work, and they have been the recipients of multi-million-dollar NHMRC, MRFF, and ARC research grants. On behalf of our Chief Executive, Amanda Larkin, and the executive of the Ingham Institute, I congratulate Valsa and her team for the invaluable work which they have done and continue to do, and I welcome you all to this research showcase. Thank you very much, Valsa.
Thank you very much indeed, Les, and for all the support and encouragement that the LHD and Ingham have been providing to us. And we are very grateful for the new initiative and the planning that's in place for the switch as a major initiative as well. Now it's my great pleasure to introduce our keynote speaker for today, Associate Professor Elizabeth Murphy. I will not say much about the background because I hope you will definitely read the bio, the brief bio that has come with the program. If I say something, you may be discouraged from doing that, so I want you to do that. But suffice to say that we have collaborated for a long time with Southwest Sydney Local Health District related projects, and it has had some impact on the policy initiatives that Professor Murphy has been also very key in implementing the Right to Beginnings program for the first 2,000 days. And it is indeed a great pleasure to hear from her the policy initiatives around child and family health that will have great resonance to today's presentations and for our work into the future. Thank you very much indeed for making the time, Liz, and over to you. Thank you, Professor Murphy.
Thank you so much, Valsa. Can I just check that everything's okay with sound and slides?
Yes,
Yes.
looks good.
Excellent. Okay. Well, I'd also like to begin by acknowledging and paying my respects to the traditional custodians of the country. And I'm meeting with you today from the land of the Camaragal people of the Eora Nation, and pay my respects to elders past, present and emerging, and any Aboriginal and Torres Strait Islander people who might be joining us today. After the initial hesitation, which is always involved in writing a presentation, I've got to say that I've really enjoyed preparing this and actually having the opportunity to reflect on just how much research informs our work at the Ministry of Health in Child Health Policy. So that's what I'm going to spend our next 20 minutes talking to you about. I thought I would start by displaying a little about our structure so that you know where the policy comes from that is informed by research. Then give two examples, the usual structure and then the quick response that we needed to develop for COVID. Then I'll talk about our major child health policy initiatives, and then some examples of the different ways that we have used research, and most recently in our decisions about what developmental surveillance tools that we use in New South Wales. So we begin with our structure. So this is the New South Wales Health Organisation chart. I'm in the cobalt blue part at the top there with the New South Wales Ministry of Health. And I imagine most of our participants today are in that bigger block there of the, shall I say, teal blue of the local health districts and specialty networks. You see to the right and the left the other pillars and statewide services that are all part of the rich tapestry that makes the New South Wales health system. So now drilling down to the Ministry of Health, these are the different teams that are within the Ministry of Health. You see the large one there headed by Kerry Chant with regard to public health. But to the right, our Deputy Secretary is Deb Wilcox, and I am working in child health in the health system strategy and planning section in what's called the Health and Social Policy branch. And I'm quite proud of the name of our branch because it's acknowledging the importance of the social determinants of health in health. So now if we drill down into that unit, you can see our branch is made up of many facets. In the green is Child and Family Health, my unit, but equally important are our partners in Aboriginal maternal child and family health, maternity and newborn, and those others that we work with as well, community health, paediatric healthcare, youth health, etc. So that's the rich tapestry of the structure of our sustained system. But of course, when COVID happened, we needed to develop a rapid response with a different kinds of structure. And hence was born the communities of practice. And you'll see on the left, the lower one in the green, the Ministry of Health, and our team led the Child and Family Health community of practice for COVID-19. And there was many opportunities for the use of research in a different way there during that time. In part, it was to develop our new guidance. We had to determine what services were essential and what could be managed in a different kind of way. And so that was probably one of the shortest deliveries of a new policy informed by research. But the other thing that we did a lot during that time was getting resources that we thought were evidence-based. We had a website of the week, websites for families who needed to know the information, and websites for staff. And then at the reflection time for there were many challenges. And I think one that I would comment on is the clash between some of the policies that would be developed by public health that might impact on clinical service delivery. And that's where research would have a very, very key point. Okay, so now let's look at our traditional use of research. And the most recent one that obviously is very important is a publication from the Journal of Paediatrics and Child Health, which showed during the COVID-19 pandemic, there was a threefold increase in ED admissions for infants that were less than 3 months due to poor growth, feeding difficulties, irritability, maternal mental health concerns. So essentially, when child and family health staff were redeployed, those children's needs were being managed by an ED that was already overloaded. This is important research, important to be published. And the moment we're having a roundtable with regard to ED management. And I suppose it's pause for reflection when or if a pandemic happens again, that these are things that we need to know to perhaps get a more balanced approach to the one that we led this time, which was significant redeployment of child and family health staff. So an important part of research used in the traditional way of publication and then action. The first 2000 days is perhaps the best example of us using research. We have the data about significant concern of children being above a healthy weight. And we have external data from UNICEF, where we know that from an environmental perspective, Australia is not doing well, being 30th out of 39 of the richest countries. And our colleagues, New Zealand, are doing far better in that context. So that's the scene setting, I suppose, the background that led to us really drilling down on the increasing and new evidence that was emerging on all aspects. That was the underpinning of what we colloquially called the roadshow where we would go and explain the evidence and the research to anyone who would invite us. And that was really important for the success of the first 2000 days of life and our strategic framework and our implementation. Now, when I gave those talks, it was really important, and I said this every single time, that this was general public health advice, that it was based on risk, not destiny, that I would try and explain risk. And I felt like during COVID, people were getting to have a better understanding of risk. And I would try and reinforce that this was not individual clinical advice. But because I was dividing up the research into these 5 topics, and everybody had either experienced their own first 2000 days or were a parent or grandparent or whatever, they would all reflect on their own antenatal experience, the brain development that was happening in their own or their child's first 2000 days, impacts of domestic violence and epigenetics and environment. And that is something I think that I need to view with caution, where research cannot be immediately translated to individual clinical experience. And so that is something, however, that was capturing the imaginations of people. So the research was a very powerful tool for people engaging in the first 2000 days of life and that strategic framework. I just want to talk about one study that, of course, we've focused on a lot with regard to the first 2000 days, and that is the Adverse Childhood Experience Study. And I think it's really quite an interesting story with regard to research. For those who are not aware, the ACE study is a pivotal study undertaken by Vincent Folletti and colleagues in San Diego, a retrospective study of 17,000 people who were privately insured, where they reflected on what had happened in their childhood and then linked that to outcomes later in life, and found that there was a direct link between a higher number of ACEs and indeed dying earlier or having significant morbidity. Now, that study had been known, had been published for quite some time, and indeed had been replicated, but there's no doubt that the publicity, the understanding of the ACE study came with a 15-minute TED talk done by a pediatrician, Nadine Burke-Harris, who simply explained how childhood trauma affects health across a lifetime. And she explained very well the biochemistry, the impact. And I think behoves us when we're thinking about research is who's the audience? How do we translate that story? And probably one of the best storytellers is Oprah Winfrey, who just loved and picked up on the link from the ACE study to trauma-informed work, and with Bruce Perry has written a book called What Happened to You, a link from changing the reflection on adverse child experience from what's wrong with you to what happened to you. So I feel like that's a supreme example of research achieving what we need it to achieve. Trauma-informed care is becoming much more common in language and I think hopefully informing clinical practice. So a great example of research and its application. When I reflected on what would be the strongest thing that is emerging, then I have no doubt that it's the impact of maternal mental health in the antenatal period in particular, impacting on that child's circuitry in utero. And now we've got MRI studies that are demonstrating that, and also intergenerational studies that have shown that stress during pregnancy can have adverse outcomes on a child's neurodevelopment or executive function, which impacts on how a child learns. And I think this is the research that we are able to highlight in the first 2000 days, because we are beginning in the antenatal period. We're not siloing life. And I think that's a critical success of the first 2000 days. And one of the things that I find is quite exciting, and it's been wonderful to be experiencing this, is that this evidence, this research of the first 2000 days, we shared with other agencies, and they said, yes, this is right for us as too. DCS understood this. Department of Education and Training understood this. And I think this is a responsibility of us in health. If we have research that impacts other agencies, then we have a responsibility to engage and translate and communicate this research with other agencies. And now I'm very excited to talk about Brighter Beginnings, which began with the first 2,000 days of life within health, but then has been picked up by Premiers and Cabinet, Department of Education, Customer Service, Communities and Justice, Aboriginal Affairs, and Regional New South Wales. And so this is really exciting times because you learn at uni how important interagency, interdisciplinary work is, but now we have the real opportunity to do that as part of Brighter Beginnings. And that has been led by Sarah Mitchell, the Minister for Education, but it's very much an interagency piece of work where if you have a look on that website, they talk about the vision, what we're doing, our approach. It's a wonderful website. And can I say it's a particularly wonderful website because it's got some excellent research that was commissioned, because once again, we're in, I think, a more sophisticated policy stage now, where if we are developing policy, if we are developing programs and services, people want to know, especially funders, what's the evidence base behind who would do what, when would we do it, and what would be the intervention. But what I'm excited about is this slide is actually on the website. So the Brighter Beginnings website has published what the evidence base is. So research is no longer, well, especially the research and work that you're doing, is no longer in silos in institutes. It's actually being out there and being used, which I think is very exciting. And these are the step-by-step guides. But I think one of the best parts that's happened with Brighter Beginnings, and I do attribute so much to the evidence and the research, is that in the last budget, there was significant funding for the evidence-based programs to be implemented. And I've just highlighted on the right there, the different ministers. We have the Treasurer at the front and Minister for Customer Services, Education and Communities Justice, all together announcing this funding base that is going to go in partnership with colleagues in Aboriginal Child and Family Centres, and to look at digitalising the Blue Book, looking at pregnancy family conferencing. So in the blue, I've highlighted what the New South Wales Health Service Delivery Allocation is. And the consideration of what we will be doing in particularly in health. And as I say, I attribute the strong evidence base that we've got there to that funding and therefore better outcomes for families. And then finally, I want to give an example of quite a specific use of research. And this is determine how we decide what child health surveillance we're going to use and screening tools in New South Wales. We do a big review of the personal health record, the Blue Book, every 5 years. And in 2017, we decided to change from the tool that we were using to a tool called Learn the Signs, Act Early. And can I say our participation in the Watch Me Grow study and the evidence that was emerging from that study was pivotal to helping to inform the changes that we made to Learn the Signs, Act Early. And we had a reference group, we reviewed all the evidence, but then decided that we'd start as a baseline with Learn the Signs, Act Early. There were benefits for parents and carers, it was free to access, it was informing them, but there were also benefits for health professionals in that it was a tool that we were able to demonstrate was more readily able to be used by child and family health, but also general practice and practice nurses. So when we came to do this again in 2022, we looked at formally reviewing all of the evidence that had happened with regard to developmental surveillance and screening tools in a systematic review based on what had happened in the systematic review that had happened prior. We then sent that evidence to all of the key people who were involved in making child health surveillance and screening work, the clinicians, the policy makers, the partners, and we held a research and policy implementation workshop because we wanted to improve our current AEDC statistics. And it was wonderful to have Professor Valsa-Eapen at that workshop, not only to present an overview of the research that was going to directly inform the participants as to what kinds of decisions that they would make, but also to be there as this invaluable resource when other issues were being able to be discussed more in a far more fulsome way that day because of her wisdom, knowledge and expertise, so that we were able to finalise that day with a decision that will be put for approval, but we felt that was as much evidence informed as it needs to be, because this is surveillance and screening that is determining 100,000 children every year in their developmental surveillance and screening. And it's wonderful as policymakers to feel very confident on the rigour of the research base that is informing the decisions of those who are going to be implementing this program. Emerging themes. I'm quite interested, of course, in what's happening with regard to technology and how that is going to address or affect attachment. And just to let you know that because of Brighter Beginnings, we're working with partners in customer service to get really drilled down direct research and evidence from our families. And this is looking at parents and their attendants with regard to developmental checks and surveillance. And they've found that there are 4 large groups of families, and that they would either be informed by needing to be informed, needing to be reminded, needing to be convinced because I have the answers myself, or needing to be convinced because I'm afraid and overwhelmed. And this is all very important research and new kinds of evidence for us to be able to look at how we deliver our services, how we deliver our policies, and who is the ultimate audience. And then finally, to say that at the Ministry of Health, we also feel that we have a responsibility to publish our work, and in particular our evaluations. And this is a very recent publication that we have put in the literature with regard to vision screening in children, and in particular because the kind of vision screening program that we run in New South Wales and its success is quite rare. And so we feel like we have a responsibility as part of the first 2,000 days, because vision screening needs to be done earlier so that there is that opportunity for intervention. So thank you so much for the opportunity to reflect. I've really enjoyed seeing how important research is in everything that we do with regard to child health policy and our service development for the children of New South Wales.
Thank you very much indeed, Professor Mappy, for that well-defined overview, all in 20 minutes. Unfortunately, because of the way this formatting of the showcase, we don't have an opportunity to ask questions or discuss. And I would encourage everyone to probably watch the videos as they come through and digest it a bit more. And if you have any questions or further discussions needed, please get in touch, either through the email that has come to you along with the program, or if you can find one of us, our emails that would work too. So without much further ado, it's time for the actual showcase to begin. We have come to the conclusion of that keynote and the opening session. I'm going to start off, but before I do that, I'll just say a few words about BestSTART. It was formed in 2018, and it's Professor Radulingam and Associate Professor Paul Che, along with myself, that lead the program. And I lead the Healthy Beginnings program sub-team, whereas Professor Lingam and Associate Professor Paul Che leads the Population, Child Health and Health Services team, and now health team by Associate Professor Daniel Lin and also Dr. Antonio Mendoza Diaz. And the equity team is led by Associate Professor Sue Wolfenden and Associate Professor Shanti Raman. And each of us are going to take a little bit of time to describe what we are up to with each of our teams, and I'll kick off with the Healthy Beginnings. Now, our vision is to make Southwest Sydney the best place for children to grow up. And in order to do that, as Professor Murphy was saying earlier, we need to address the challenges of this century. And it's very different from probably the previous centuries, because currently the biggest problem is the non-communicable diseases. And that includes speech delay or autism or obesity or asthma. And we're going to hear much more about all of these problems. And if you don't act early, and that's where the health burden of the future generations is going to be. And childhood, especially in the first 2000 days and up to the cusp of adulthood, offers that window of opportunity to make things better for our children. And it is said that the late intervention is costing Australian government an estimated $15.2 billion annually. Now, if you do zoom into the Southwest Sydney, it has a population of just over 1 million, close to a third are children and young people. And the prior work that we did before BestSTART formed, we found out that the critical issue is the inequity in access to services in Southwest Sydney. And that means in preschool children, it's not engaging with the developmental checks, just to know how kids are going in order to be acting early. And we found through a cohort of 2,000 children born in Pakistan, Liverpool Hospital, the Watchman Group study, an inverse care law and significant inequity. Those from the biggest disadvantaged suburbs and households with the highest risk for developmental problems were least engaging with our health services. And so obviously, if they are not engaging, that means they are not able to get early intervention. So next slide, please. If we can be to give a fairer goal for the development and healthy development of our children, what should we do? So we reflect on the AEDC data that the Australian Early Development Census. So 1 in 5 children nationally are starting school developmentally vulnerable. And in some parts of Southwest Sydney, it's up to 1 in 3. And if you look on the right slide, Fairfield, for example, 28.2 against a New South Wales average of 19.9. And we know from neuroscience that the key to better trajectory is early identification and early intervention. And it's totally unacceptable that our children are missing out. And there is a significant socioeconomic gradient with inequity. And one example is the language and cognitive development. And we see a vocabulary gap between rich and poor emerging really, really early on. And so by age of 3, children growing up in poorer neighborhoods or in lower income households will be hearing up to 30 million fewer words than their privileged counterparts. And you can see by 18 months or 2 years, already that vocabulary gap and the ability to see that language processing skills differences, and that then sets them into school readiness and into their future life. So we need to really start early, and lack of stimulation in language alone can make such a big difference in their outcome. How do we reverse this inverse care law became our next question. And in our study, we found that currently those who are accessing those developmental checks and prevention health promotion programs are mothers born in Australia, primary language is English, higher education and high income, and firstborn children. And in really, we need to be doing something totally different because that's not our demographic, totally the opposite. So we decided to go to where the children go. If they are not coming to us, that's the only option available to us. And literally, Sue and I went to 2 different directions to go to where the children go. And that is, I went to the GP sector saying, surely that's the only universal care that everybody has got, and we should be able to catch them through that. And 95% of kids get the vaccination. So why not piggyback on that? And Sue went to the early childhood education, supported play groups and that early engagements that kids have with other facilities, and she'll be talking about that. And in that Watch Me Grow program, what we then did was to develop a web link to engage and empower parents. And that's when the Watch Me Grow electronic platform started to emerge. We had the Oran Park as the primary site, doing it in the JP waiting room. And then we've got a Ramshioti grant to scale it up to see, well, is it just feasible? Is it just acceptable? And then had further grant for saying, is it possible to identify autism through this? And that was Southwest Sydney and Melbourne. And then we had the NHMRC partnership grant for New South Wales Health Queensland Health to kind of combinedly look at this in GP practices across Southwest Sydney and Brisbane. And then what happened is COVID. And then COVID took away all that waiting room opportunities. People were having vaccinations in the car parks, and there we go. And it also highlighted something else. If you look on the left, the Noble et al. Report by Victoria University, these are children living in households experiencing significant employment stress, school-aged and preschool children. Of the 10 regions across Australia, there were 3 from Southwest Sydney: Fairfield, Bankstown, and Campbelltown. And that really tells us where we are sitting in our community. And if you look on the right, the AEDC data is a splitting mirror image. The more disadvantaged, the more rate of vulnerability in children. So with the What Should We Grow we had to kind of be innovative again. So we pivoted to sending the link to families at homes, wherever there was opportunistic engagement, whether it is supported play groups or whether it is anything. So we then had the tiered care model to follow up on the pathways. And the first would be kind of into the community, use the Watch Me Grow to engage, identify those who are having issues, provide them additional resources. Then for those who need identified problems, provide targeted support. And then we also realized that that alone won't cut it, just going with the child's issues. Parental mental health and the social needs of the family are really going to the make or break in terms of them engaging and benefiting from what we are going to provide. So that's when the next set of research programs came about. So from that little seed funding that Sue and I divided up and conquered, we have been able to kind of have significant further investments. And the last one in the yellow box are the 2 that we've got in this year. So the first one is a tiered care model, starting with Watch Me Grow, identifying them at the tiered level 1 to 4 that I showed, and to be scaled up in 3 communities. One is multicultural community in Karama, regional, rural, and aboriginal community in Tari, and a low socioeconomic community in Windaroo in Western Australia. And Sue will be leading it. We'll be hearing more about it, the IRC linkage grant, which is again to look at the hub idea. So once we identify kids, how can we provide services in an integrated way? And that's the focus for that IRC linkage grant, again, Karama and Tari as the kind of 2 different, widely different communities being brought to the forefront. We wide a knowledge translation piece that might be applicable to across Australia as a whole. So I think we now have got an integrated approach covering the first 2,000 days, and we've got the double jeopardy of high disadvantage and system failure. And the way to do this is to cumulatively buffering against the cumulative risk. And this is the how the first 2,000 days program would look like. It's a busy one, but you can see that it's carefully thought about in terms of how we would implement such an integrated service station. It's now my great pleasure to introduce a team led by Professor Lincoln, who will be covering the Population, Child Health and Health Services team, and Professor Lincoln will be joined by Associate Professor Paul Che, who's the other co-director for BestSTART, and the others will all be introduced by Thank
you so much, Councillor. So it's a real pleasure to be able to be here and present for BestSTART Southwest Sydney. We've been going for 4.5 years now, and we've actually been able to develop a research portfolio around healthy beginnings, health services research, and other areas of research, including health inequality, which is actually quite innovative and forward-thinking. Next slide, please. So as Vas has pointed out, we've got a large population in Southwest Sydney that is growing very rapidly. This population is unique in terms of its multicultural makeup, that 41% of children being born overseas, but also the morbidity that is in this population, from obesity to poverty. The social determinants of health are rife within the community, but there's huge amounts of resilience within this community as well. Thank you. So we as a Best Start organisation really put our eggs in the healthy beginnings basket. Okay, so we wanted to build on the strength that Valsa and her team of researchers had. And so from a Best Start perspective, we really tried to focus our health services and methodological resources into that healthy beginning stream. And so our population health and health services research area of research, or stream of research, has lagged behind somewhat the healthy beginning stream. However, I think we're really making some forward strides, and I'm really pleased about the progress that that particular stream has made in the last couple of years, especially. Next slide, please. So how are we doing as a country? Australia is doing very, very well, actually, in terms of 12th, alongside Israel, Denmark, and Austria, in terms of child deaths from live births, for example. However, Australia, like the US, is really quite an inequity. Inequity is a real problem in our communities, both in terms of Indigenous mortality, major cities compared to outer city regions, and then our regional and rural areas as well, having much higher morbidity and mortality rates for our children and young people. And as Valsa pointed out, some of the areas that we work with in South West Sydney are some of the areas of highest deprivation anywhere in the country. Thank you. So from a health services and a health systems perspective, we need to really understand the problem. First of all, we have huge population growth, especially in areas like South West Sydney. Unfortunately, children are making up an ever smaller proportion of GP visits. However, they're also making up an ever increasing proportion of increased emergency department visits, which is putting huge amounts of stress on our health system and our health services. Over the last 3 years, referrals to non-surgical outpatients in our hospitals have been increased by 100%. In some outpatient clinics, the waiting times for things like ADHD assessments, autism assessments are 12 to 18 months. And we have clinical colleagues in the audience today that know that and actually can see that within their services. The Henry Review talks about actually integrated services and delivering services and strengthening primary care workforce for especially complex behavioral difficulties, mental health problems, and developmental disorders. And that really marries in with a lot of the previous speakers. The quality of care, unfortunately, across our health sector for children and young people is inadequate, with Braithwaite's study, Care Track Kids, showing that about only 60% of care was evidence-based, and this was lower in primary care than secondary and tertiary care. Thank you. 2 minutes left. You're joking me. Oh my gosh, I've only got 2 minutes left. I've got a whole bunch of slides. I thought I had 20 minutes for this talk. No? Okie dokie, I've got 3 people. I thought I had 20 minutes. Next slide, please. Oh, 20 for the whole thing. Okay, so what we've shown here in this slide is what we're able to do within our, gosh, you've really thrown me. Okay, so what are we seeing? What are we showing here? What we're showing is a huge increase in demand for health service use, and especially within mental health. And that's a 56% increase in mental health admissions and emergency department attendances. Next slide, please. And next slide. Next slide, please. Next slide. Okay, we're going pretty fast. So what we showed is that we need to think about new ways of developing and delivering care. We need to think about GPs and paediatricians working together to deliver care close to home, which is of high quality, and be able to deliver care that is actually appropriate for the needs of the child. If a child has leukemia, they need to be seen by an oncologist. We're not saying that they should be seen by a GP. However, if they've got a cough and a cold, they don't need to go to the emergency department. And that's really the difference here, using the whole of the health system in the most appropriate way. Next slide, please. So what we've tried to do within the South West Sydney area is to think about the strengthening care for children model, where GPs and paediatricians work together. And we've called this project Sustain, and we've been successful developing and obtaining TRGS Translational Research Grant Scheme funding for this model. And South West Sydney is one of our key partners within this project. And it's looking at modular training using the SCHP, the Sydney Child Health Partnership, which used to be called the Diploma of Child Health, fortnightly virtual co-consultations, monthly lunch and learn sessions, and then weekday email and telephone support. So actually, in a way, what you have is phone a friend. You've got a paediatrician when you need them, as a busy GP working in Fairfield or working in Liverpool, that can actually phone a friend, phone a paediatrician to get some support. So to deliver care for that family closer to home, so they don't have to go to hospital, wait on a waiting list, or be seen by a private paediatrician. Next. So we are doing this evaluation to reduce referrals, improve quality of care, and prove that this is cost effective. And I wanted to thank our partners in South West Sydney Primary Healthcare Network for their support for this project. Next slide, please. So Sustain is, we're using absolutely gold standard methodology, and we've tried to help with a lot of the Healthy Beginnings trials around the impact evaluation, the cost effectiveness evaluation, and that implementation evaluation at scale. And this trial is the step wedge trial. Next slide. New initiatives that we've got funded is the Best Start platform. We're working with Cedric. So those analyses we were seeing about increasing health service demand can be actually done locally. And it's absolutely essential that we continue that Best Start research platform, so we can actually respond to the local needs of health service users. We've just been successful with the local health district on a partnership grant and New South Wales Health around maternal smoking cessation. And we've just got a $3 million grant, NHMRC partnership grant across 2 states. And we want to be thinking about these big scale projects. And we're thinking about obesity with Faye Southcombe and asthma with Nusrat Hamira and her team. So I'm going to pass on now to who's next? Is it Nusrat? After you. Okay, thank you very much. Oh, sorry.
Thank you, Raghu. My name is Paul Che. Now, a key goal of Best Start is to enable clinicians to undertake research as part of their clinical work. So the next 2 presentations is an example of that. So the GHK service is a new child health management service that is developed in southwestern Sydney from the ground, and it was developed with an evaluative framework in mind and with a mindset of having research to guide clinical work. And so that's an exciting piece of work which Faye will present to us. And secondly, Ryan N, who is a paediatrician, and Taylor, who's a research nurse, will present on an asthma project in Liverpool Hospital. I can tell you that this is the first research project that has been undertaken at Liverpool Hospital Paediatric Ward. So those are all exciting capacity building projects which we will showcase now. Thanks.
Thank you. Good morning, everyone. So I'm going to talk to you briefly about the Growing Healthy Kids initiative in southwestern Sydney. So it's a broader initiative, but the part that I have responsibility for is the implementation of a weight management service. So we all are well aware that weight management is an issue across the globe. And there's some global and economic patterning that happens, which we're probably all well aware of. But the importance of this slide is that In southwestern Sydney, 17% of our children and young people are affected by obesity, and that's a doubling when we compare it both nationally and globally. Next slide. So obesity, even in paediatrics, is a complex progressive disease. It's associated with multiple life-limiting diseases and premature mortality. Without intervention, it is very unlikely to spontaneously recover. So weight loss does improve obesity and associated diseases. How much weight loss is really not well understood in a paediatric context. We know really small changes in BMI have really big impacts for children's well-being. Next slide. So what we do know from the literature is that diet, exercise, often combined with behaviour change initiatives, is effective in reducing BMI in children. Lifestyle interventions which induce weight loss do activate some compensatory biological mechanisms, and they do lead to weight regain. And this needs to inform our future structuring of our services. But within obesity management, there's a really high degree of treatment variability. Some children reduce their weight significantly and others do not. So when we set up Growing Healthy Kids, we set up with an evidence-based dose model of care, and we very quickly recognised that we needed to apply a more precision medicine approach. So to do that, we looked for some research partners. We knew we didn't have the research, as a clinical team, didn't have the research capability to understand how to translate that rapidly into change our model of care into the interventions that we're providing. So we set up a partnership with BestSTART. Raghu is our primary partner on that. And we looked at building our capabilities within our clinical team. So I started to undertake a PhD, and one of our clinical nurse specialists is doing a Masters of Philosophy. We also had some resourcing through BestSTART, which supported a research assistant. We built our systems around data capture, intake, triage, and reporting. And these are skills that BestSTART helped us build within our team so that we could maintain these systems ourselves. We also got a lot of support from BestSTART through mentoring, writing, statistic, and the scientific methodology guidance. So we capture a lot of data, but we might skip through this. If anyone's interested, we can talk about it later. So what have we produced so far? So we have produced a systematic review, which has just been accepted for publication. And how did this inform practice? So when we titrate the evidence from the literature down to individual clinical practice, we really don't know what intervention works and for what child does that work. So when we did a systematic review, it informed our clinical protocols, which we now use and we'll be testing the outcomes. We also have a paper in for publication, which looks at it's a descriptive study of our baseline data. So we might take a quick snatch at this. So what we found when we compared BMI and used a different tool which looks at 4 domains of wellbeing for children affected by obesity, we found that the children who attend our Growing Healthy Kids service have poor metabolic health. 75% of them have pre-diabetes, 52% have abnormal lipids. They also have poor mechanical health, so there's a high degree of OSA and some musculoskeletal pain. In terms of mental health, we have a really high representation of mental health concerns, and a lot of these children have multi-morbid mental health concerns, overrepresentation of ADHD, as well as some other mental health concerns. Within this tool, we also capture the social milieu, which is a way of describing and understanding systematically the environment in which we're providing clinical care. So within this domain, we found that 75% of our children, which is not unusual for the area in which we work, are from socioeconomically disadvantaged areas. A quarter of our children experienced bullying, and half of those experienced bullying which impacted their school attendance. So what are the implications for practice? So our future thinking around this is that children, I guess, of preschool age are really poorly represented in the literature. The literature is highly selective, whereas our clinical practice has an overrepresentation of those people who are often excluded from research. So we have a lot of preschool children, we have a lot of children with developmental comorbidity, and those with severe obesity also feature really highly in our service, but are underrepresented in the research. So we still need to understand more about the type of the interventions, particularly in the weight maintenance phase. So as that people develop those compensatory biological mechanisms, they drive weight regain. And we need to move from a dose-based service to one which is responsive and looking more longitudinally at children's engagement. There's also a need for some really explicit guidance on some things that we use clinically but are really not well developed in the literature. Things like prophylactic medication use, like metformin, or even understanding energy reduction and how that correlates to change in children. So some of the strengths and limitations of integrating research into clinical care. So our collaboration has really enabled research. We've been able to rapidly translate that into changes into our clinical practice. The data capture is now embedded in clinical care, I think with the envy of some other services, because we were able to set this evaluation framework up at the initiation of the service. And it's our clinicians who routinely capture this data. Some of the barriers are time and resources, but also bridging that gap between research and clinical care. I think one of my supervisors recently asked me why I hadn't measured all the children on the same scales. But when I think practically in a clinical setting where you've got 10 children on site at any one time, that room that you booked might not be available, the patient might be late, or there's lots of reasons why those things can't happen in that practical setting. Another barrier, I guess, for us is filling our skill gaps. So some of the things, particularly around statistics and scientific methodology, is something that we've relied heavily on our BestSTART partnership for. Thank you.
That's Mark. Hi, I'm Ryan. I'm a PhD candidate. I'm one of the lead investigators on the COMPASS project, which is talked about today. I want to begin firstly by acknowledging the traditional custodians of the land, both past, present, and future, upon which we sit today. The COMPASS project, next slide. I thought I'd start with the context for our project. So, what's the issue with SAM, you may ask? Well, 6 presentations in 12 months is very frequent hospital presentations, and we know that frequent hospital presentations are a marker of poor disease. They can result in significant school absenteeism, significant burden upon families with missed days from work, and psychological stress. In our previous work, the cross-sectional study in 15 LHDs in New South Wales, we identified that parents receiving up to 8 different types of asthma action plans within different, not only just within different hospitals, but within different departments, which understandably parents and staff found very confusing. On interviewing the local health professionals, marked variations in care and uncertainty around post-discharge and follow-up were identified, which then provided the fuel to do a systematic review, which identified several key interventions that can reduce not only asthma hospitalizations, but overall improve asthma outcomes. So we proceeded with a quality improvement project within Sydney Children's Hospital Network, which focused on a number of the key interventions highlighted in the systematic review, including a standardization of asthma discharge and coordination with GPs and text message follow-up reminders. And we find that this had a 57% reduction in ED presentations with asthma in children. And this was very useful pilot data to roll out our project on a grander scale, both within Liverpool Hospital and several rural LHDs across New South Wales. So the COMPASS project, in a nutshell, it's a randomized controlled trial focusing on 5 to 16-year-olds attending ED or admitted to the paediatric ward with an asthma exacerbation at Liverpool Hospital. And the aim of the project is to assess the effectiveness of a technology-enabled asthma model of care in reducing asthma-associated healthcare utilization. Our primary outcomes are focusing on, firstly, the health service utilisation, but second, also important secondary outcomes, including asthma control, asthma quality of life, medication adherence, and parent and carer reported experiences with the project itself. Next slide. So the key interventions will be standardization of asthma discharge, which, as you can see, will incorporates a large amount of resources, including an asthma action plan, the asthma in your child, which is available both in hard copy and e-booklet form, and translated into 3 major languages, including Mandarin Chinese, Arabic, and Vietnamese. Letters for GPs in schools with best practice tips, and links to online resources for both parents and healthcare professionals. The next one is linkages with community services. So we had identified that the communication and between hospital-based services and community-based services could be better. And so our aim is that through these letters and follow-up emails that we can improve care coordination following discharge. So our project is certainly in its early stages. We began recruitment in May 2022. And our hope is that the project will be completed within the next 18 months and show that we can, in fact, reduce asthma hospitalizations in children within Southwest Sydney. So I will hand over to Taylor, who is our research assistant on the project, to talk a bit more about the research nurse perspective.
Thank you, Ryan. My name is Taylor McGee. I'm one of the research nurses or working on the research project with Ryan and the other team members. I'm a 5th-year registered nurse working on the paediatric ward, and this happens to be my first role in research. So it's been a wonderful learning experience, a beautiful team. I have had, any slides? It's just so I've had a few, I guess we could call them hard falls. Getting nurses and medical staff to adapt to new practices has been an interesting challenge, and one that we are still attempting to work towards. But I have met many wonderful people in this step and have learned to work around different things. I am trying to find the best way to train staff in new procedures. So working with large groups of people in a busy environment like the emergency department is not an easy task, but we have had great help from some of the lead nurses in the ED, so that's been amazing. Differentiating between viral induced wheeze and asthma is, although we can as health professionals differentiate, the documentation that we sometimes see doesn't provide us with all of those answers. So that can be another hard fall when trying to select participants for research. The small teething problems for myself was getting to know the new computer programs. Electrics and RedCap were not something that I had used. So I had to learn on top of everything behind the research to work with these new programs. And the last thing is I have spent the last 5 years bedside nursing in pediatrics. So sitting at a desk and not being on my feet, not answering that call buzzer, that's been a challenge for me. So I can still hear the buzzers in the office and think, oh, I'm going to jump up. But all in all, I'm lucky enough to be able to split my time between the ward and research. So I get best of both worlds. A learning experience. So again, we've got computer programs. Although it was difficult, I have picked that up, I think, with great ease and amazing programs. So great to learn something new. Understanding the immense work that goes behind research is been absolutely amazing. I never realized what Nurse Right, you have put behind the scenes and the paperwork, and Ryan, what you're dealing with to get ethics and everything going. So learning that has been amazing. And just finding other research nurses to link with. Dr. Che with the pediatric team has helped me to link with a few people who are able to answer those few questions that have been helpful. Communicating with parents has been another challenge. So not everyone enjoys a phone call. SMS is a way of the future, I guess. It's a few programs people like to use on their phones, so getting used to that has been another challenge for me. Scheduling, I guess we don't always have a full day, and then other days it's 2 days in one. So I'm working with that and changing the hours to suit, which is the flexibility of working time. And then I guess one of the best things I've realized as this new role in research is what you guys are all doing and what I am doing now is shaping the future of our practices. And it's just amazing to see how that is formulating. So big thank you to everyone.
And thanks everyone, thanks Taylor and Ryan. I just quickly wanted to end by thanking our amazing partners at Southwest Sydney, especially Paul. Paul, I'm just so grateful for the continued support that you have given to us. None of this would have been possible without you. And I just wanted to also thank the nurses, because I think for projects that requires active recruitment of patients from the hospital and implementation of intervention in the hospital, nurses are the key role, key players in that project. And I can't be more grateful to all the nurses who are actively involved in our project, and also Taylor. So yeah, I just wanted to thank everyone. It has been amazing working here.
Thank you. So I suppose in order to just close up this session around health services and population child health research, I think what we'd like to say is that we're making progress in this area. And I think the speakers today really showed that the capacity building within Southwest Sydney that we're doing, as Paul mentioned, from a clinical perspective, is quite remarkable. So I wanted to say thank you to Paul and the clinical team for all the support that they've been giving us in Southwest Sydney, to Les, and obviously for the exec for setting up the Best Start at Health Services Research team. So over to you, Vanessa. Thank you.
Thank you very much indeed. And the next theme is mental health. And we will have Mr. Ben Miller and Associate Professor Daniel Lin, as well as Dr. Antonia Ventosa-Diaz, providing various projects that's happening under the mental health theme. And I'll first introduce Dr. Lin to come over and then get the team going.
Oh.
Hi everyone, thank you for the opportunity to present on Towards Zero Suicide. And I'm Mr. Ben Miller, Programme Manager for Towards Zero Suicide at BestSTART-SW. And the Suicide Prevention Outreach Team, SPOT, which is what I'm presenting on today primarily, is what BestStart is doing research initiative on. So the problem, but also the opportunity, is that suicide is the leading cause of death for people aged between 15 to 44 years of age in Australia. Why is that an opportunity? Well, we also know in our region that for every 5 deaths from suicide, 4 people are not known to our district. This represents obviously a great opportunity to change what that looks like in terms of people not taking their lives. So just to flag, 80% of our community at the moment do not get their needs met by our LHD in this region. And that is the opportunity I want to talk to. So next slide, please. So as I said, SPOT is part of the Towards Zero Suicide Initiative. It's actually a 2-year, well, initially it was a 2-year premier priority from 2020 to 22. And in June of this year, it became permanently funded. So from June 2022, it was permanently funded. And that makes it very exciting for us going forward, because we can now really start to deliver this, knowing that we've got certainty of funding. There are 3 initiatives across our district. One is called Zero Suicides in Care. And this is establishing the, I guess, staff's ability to screen people who may be at risk of suicide in our region when they come into contact with care, and then appropriately direct them to the suitable resources to help them through their next stage of recovery. The second part of that is the spots, which are a new service, and I'll talk a bit more about that, and that's what this research is linked into. We also have something called the safe havens, and next slide please. This is a picture of the safe haven we have in Campbelltown. We have a second one open in Liverpool, and these are spaces that people can go to after hours, in the evening, over the weekends, at their time of need. It's a non-clinical space, and people can receive care suitable for there. So that's hoping to address that, provide new and different services that allow us to address the 80% currently we're not supporting. So, second new service is the Spot. Again, this is a warm and welcoming service. It's a mobile service, this one. So we go out to people in the community and see them at their place of need. And two, a really key part of this is that the team is made up of half clinical staff and half physical workers. Physical workers have a personal experience of suicide and stress. And those two components work together in teams to respond to people in acute crisis and then refer them on to other supports. So what I really wanted to stress here is, as a new and different service, the Spot, which is what's so exciting for me and why this research partnership is so exciting, is that neither the peer support worker or the clinician are in charge of the other, yet both are accountable for delivering care. This has never happened before in health. And from my point of view, it forces us to look at, I guess, it changes the way the care dynamic is delivered. Firstly, any person receiving care from our support services can effectively has two service providers coming at it from a different point of view who can help to provide, to allow them to choose the type of care they want to receive. And that is really subtle and very important. It also reduces the power imbalance because those two staff members aren't in charge of the other. And so that is a key part of delivering high-level mental health and suicide prevention care. Because traditionally, power has always been with the provider, not with the person receiving care. So I think that's it. That's all I had to say. So yeah, so from my point of view, very exciting to do this partnership. I'm looking forward to hearing what Danny will share the next stage about.
Thank you, Ben. So hi, everyone. I would like to talk about how we're going to evaluate the program that introduced by Ben. It's part of the Towards Zero Suicide initiative. So we're going to talk about the framework of method of evaluation. Okay, sorry. All right, the framework of evaluation, how we're going to evaluate that, what would be our primary and secondary outcome next. So this is like this next chapter of our research goal, try to focus on evidence-based practice. So the first one is trying to evaluate the effectiveness of Spot service in terms of whether it can reduce the ED revisit, which would be our primary outcome. And the second one, we want to determine the feasibility, acceptability, appropriateness, fidelity, and sustainability of the program compared to the standard care. And finally, we also like to know, and a very important aspect of the evaluation is that we want to know what might be the individual attribute, the characteristic that can predict the intervention outcome, as well as whether the individual would like to stick to the program and adhere to the program. So the study, we will try to roll it out in two phases. This is like based on phase one. We're going to focus on just the individual, the clients go to Spot. So, but in phase two, if we receive the further funding, we'll be able to expand into the randomized control trial. the spot versus the standard care. So the age group of these clients, we are targeting at the most at-risk population, between 16 and 44 years of age. And we're going to measure the outcome at 3 time points: baseline, 4 weeks, and 12 weeks. And in terms of the outcome, like we try to strike a balance between the strength and distress. And most conventional study would like to focus on with just the suicide risk, and just like our base, the primary outcome, the revisit to ED for suicidal event. But we will also like to look at the resilience, which is considered the strengths in the context of suicidal prevention. And we also like to get the perspective from multiple stakeholders. That's why we have the qualitative study component in this project. So this is the table summarizing the outcome we're going to measure. And as you can see, we have the primary outcome, and also we have the questionnaire to touch upon the secondary outcome. So primary outcome will, like I said, focus on like the utilization of the emergency department services. But we also have other questionnaire to touch upon the resilience and the suicidal ideation, and also the general health condition, using the health and the national scale as a questionnaire again to assess the outcome. And finally, to get, as I mentioned in my previous slide, we want to try to get the perspective on multiple stakeholders. So we're going to have an interview for the selected stakeholder, including the clients, clinician, staff, using the CFIR framework. We're going to get to that in the next slide. So quantitative data analysis, it will be our major tool to understand to evaluate effectiveness. So we're going to do the intention to treat approach, because there might be heterogeneity in terms of how they're going to shift to their treatment journey down the track. And the primary outcome will be the ED revisit. And because this is when we expand into the case control, they kind of study design, these are not probably they will be not that feasible to have the randomized control trial. So we're going to do the propensity score matching to make sure that the individual allocated to treatment groups is not because of the severity. We will control for that. And the secondary outcome, we're going to use the repeat measure and COBA method to analyze the result. Missing data will be imputed for secondary outcome if the proportion of the missing data is less than 20%. And so we will try to avoid the bias process. So this is qualitative data analysis. The framework basically that we need to look at different domain dimension, outer setting, process, and inner setting to understand that how with the multiple stakeholder view the evaluation and also the intervention itself. So we try to consolidate this framework to understand the target, the outcome we want to study, such as feasibility. So so far we have completed the phase 1 study in terms of qualitative study result. So according to the interview results from the staff member, we identified several topics associated with the SPOT evaluation, including like leadership, holistic care, and safety, and the recovery-oriented support, etc., etc. So this will be the foundation for us to understand how we might be able to improve the component down the track. And 4 major things have been identified as well: barrier to healthcare, enabler, limitation, and improvement. So then what I'm going to do next is that we're going to proceed with the single arm trial to complete the pilot data. And we will focus on the individual feature to predict the intervention outcome. But we're going to seek further funding to expand the scope of the work using quasi-experimental comparison between the two treatment group. And we will try to identify the individual treatment that will be the foundation for us to understand what might be the factor contributing to fidelity and stability and appropriateness. Thank you. Tony.
Thanks, Dan. All right, guys. So I'm going to talk to you about some of the initiatives that we have in the area of consumer and community involvement. And in the few minutes that I have, I'm just going to give you a little taste of a couple of the projects that we're doing at the moment. So next slide, please. And also to start with a brief acknowledgement of country, just saying that Aboriginal communities were a big part of this work as well, and that it's not just a kind of I think that we do at the start of this presentation, it's also about kind of actively engaging Aboriginal people and Aboriginal communities in the research that we do. So I'll be talking about our work in consultation with schools and a little bit of our work in integrated health hubs. Next slide. So in our consultation with schools, this is some work that we do with the schools right here next door in Liverpool. It's work that we have been doing for a number of years, and so this has allowed us to really take a journey with them throughout the pandemic. When we first consulted with young people, we realized that mental health was an area that was a big priority for them in terms of their health, and that was quickly replaced with COVID as it emerged. We have been able to consult with them throughout the pandemic, and so we have heard a lot of stories of resilience as well. We've been surprised to know that a lot of young people were able to get together using digital technology and still being able to hang out and to have fun, even when they were not seeing each other face to face. Something else that we noted was really interesting was a sense of appraisal of face-to-face interaction. So when we first spoke with them about mental health, for example, the solutions that they were coming up to some of those health concerns were to do with digital innovations. So they wanted more chat-based services and things like that. Whereas when we consulted with them towards the reopening of things, they were much more apprehensive about those digital services, and they were looking for face-to-face contact. They were valuing that a lot more. And it was also really interesting to see a very large decline in overall trust. And so that's what that section to the right of the slide there is showing. So we were noticing that there was a mistrust of school, a mistrust of government, and a mistrust of health services. And you can imagine that the kind of draconian lockdown measures that were used in Southwest Sydney contributed to that significantly. But it was interesting to know that had also spread more broadly to things like school and health services. And so we were also kind of wondering, well, what do young people trust? What do they put their trust in these days? So there were a number of categories that we kind of classified as being on the edge of trust, like their peers, their family. And the reason why it was like that is because in some cases they can trust those groups, but in some cases they can't. And so we see a real mix there. And what they trusted was intangible, so the things that they felt were most connected to them and that they felt were most concrete. Now, some of these things were not things that we necessarily want our young people to be placing their trust in, but they were things like money. There were things like influencers who they felt were more real because they were talking directly to them. And so there was a real sense of a realignment in where they were placing that trust. Now, throughout this work, we've had a number of challenges and changes in staff because of the time that it's taken, difficulties with engaging young people. So some of the sessions have been have been done in Zoom, which is not ideal when you're trying to do some consultation work. But this has allowed us to take some of those concerns, reformulate them into research plans that we can then present back to the children and young people to see if these kind of research ideas are meeting the concerns they brought up, and to try to work with them to come up with research plans that are going to be working for them. Unfortunately, the slide reformatted a little bit, but you can see the conversation there. The real different perceptions that people have in whether they can trust their parents. And so to give you a brief example, some of the projects that we had come up with were things like building trust in health professionals by creating guidelines for therapists that were actually written by the young people regarding how they want to be treated, or getting parents on board with the concept of mental health, but promoting it in spaces where we normally don't go, like through religious leaders and imams and so on. Next slide, please. So that's some of our work with consulting with schools. We also have a fair bit of work now around integrated health hubs. And so what does this mean, this kind of integrated, this health integration? Here I'm talking about horizontal integration, so across different disciplines, vertical integrations, so in terms of primary, secondary, and tertiary health, and temporal integration, so integrating over time, being able to follow up families. And so that's what I'm talking about when I talk about an integrated health hub. Slide, please, thank you. In our Maya, we're able to collect some quantitative data with the community, and here what we're seeing is the results between baseline and 3 months on strengths and difficulties questionnaire, which is that kind of mental health screening type of question. And you can see that broadly across domains, the kids that engaged with the hub were getting better. However, we didn't see the same differences in older children, but the differences did seem to be maintained at 12 months. So even though this was just in those 3 months, they seem to endure. And if you can click ahead, thank you. We also see a a sort of benefit in behavior incidents in school over a 12-month period. And so what we see here is that between baseline and 1 year later, in part because of the effect of the pandemic, behavior incidents actually went up overall. So they went up for everyone, both the children that were accessing the integrated health hub and the children that were not. But interestingly, at the year follow-up, we don't see that difference in severity that we did see at baseline. And so in that sense, we felt that the hub was protective of the children. Thank you. Next slide. And this allowed us to develop frameworks that we're hoping that we can adapt and use with different communities to develop other kinds of integrated health services that might include things like social services and health services. And here what we have is some ideas about how you can do that work. And this is work that has come directly from our consultations with the community, with different consumers. But it comes out with a bit of a catch. Next slide, please. When thinking about this work, a friend and researcher said to me, well, this is completely counter to a community co-design approach because you're coming forward with this framework and you're trying to impose it on different sectors of the population. And I think that leads me to some interesting reflections about how can we build on previous work? When does co-design come in? Do you need to co-design with communities from the start and always assuming that you have a tabula rasa, or is it okay to be informed by some of the community consultations that you have done before? And I don't have an answer to those things, but those are kind of some of the questions that we're grappling with as a group. And I think it's really important that we continue to critique each other and try to make our research better. So that's it for me. Thank you.
Thank you very much indeed, Tony, Ben, and also Daniel for that wonderful presentation. And it's now time to move on to our next theme, that's equity-focused work. And pleased to introduce the next speakers for that theme, Clinical Professor Stephen Buchanton and also Associate Professor Shanti, presenting on the work that they have been doing in the details.
Great, thanks, Valsa. Hello, everyone. It's a great pleasure that on behalf of the Translational Research Grant Scheme team, I present on our first 2,000 days Care Connect, the first 2,000 days integrated model of care for migrant and refugee women that we are running in Southwest Sydney, Southeast Sydney, Southeast Sydney and Northern Sydney. And also thanks to Tony for setting up the evidence and the description of a hub. Next slide, please. So I think we all know, and this has particularly become more apparent post-COVID, that we really do have quite a fragmented child and family health, early childhood education and social care system that's hard to navigate for many of us and would be particularly hard to navigate if you have language and cultural barriers and socioeconomic barriers. We also know we kind of have a drop-off where we lose women from their antenatal journey to their postnatal journey, which is a really key kind of point for continuity of care as highlighted in the first 2,000 days policy. And so this project came around as a way to think about how can we better engage with migrant and refugee women in the first 2,000 days of life, particularly from the time they're pregnant to their children's first year of life. It was based on some pilot work that we had already done, where we basically showed that if you took child and family health nurses to sites you knew migrant and refugee women were already engaging with, such as multicultural playgroups, you could actually increase engagement in the child and family health checks, which are really important for picking up difficulties with growth and development early and linking into early intervention. You could double it basically from 30 to 60%. The current rate for children going to child and family health nurses after 12 months is about 30%. So that's really important in thinking about this as a model of care. And we also had some data that showed that navigation was really important in supporting women from that antenatal to postnatal period. And what you can see on my right is essentially a schema of how the hub works, with women coming in all sorts of areas, all sorts of entry points, and having lots of options being provided by NGO partners, such as a family support worker or a supported play group. And within that context, developmental surveillance and growth and developmental surveillance occurs with our health staff and linkages to further services. Next slide, please. So the aim and the objective of this TRGS was basically to fill a really important hole, particularly in Australian evidence, but generally in terms of what's the evidence that a hub like this might actually have an impact. So improve the number of children having their child and family health checks to 12 months of age. That's because of our timeline for our TRGS, we've chosen 12 months. And thus resulting in improved identification of developmental problems, also supporting mothers' wellbeing and addressing unmet social needs. Key to this, and I'm so glad we've done this, is an implementation evaluation, which really looks at how does a hub happen? Are they feasible? Are they appropriate? Are they acceptable? And then we have another component looking at cost effectiveness, including, and you saw Liz Murphy refer to this, whether we reduce hospital visits or not. Next, please. So we're using a pragmatic trial design. Essentially, this is occurring across the 18 outer services of Liverpool, Fairfield and St George. We're basically targeting expectant mothers more than 20 weeks gestation or who have recently given birth, who identify as migrant or refugee, being in Australia for less than 10 years from a non-English speaking background. And it's really easy. If you come from the hub postcodes, you are offered the hub. What's your consent statement? And if you don't come from a hub postcode, you just have your usual services. Primary outcome is thankfully out of EMR data, so that's really great to be able to collect that once people consent, and we do that at 6 and 12 months, looking at their engagement with child and family services. But we also have a baseline survey as well, and a 6-12 month survey looking at whether unmet social needs have also been addressed. And at the end point, we'll also be doing a data linkage with the Cheryl data sets to look at prenatal data collection and emergency department data collection. Next, please. Oh. So this is where we're at. We had a little thing called COVID interfere quite a lot, to be honest, at the beginning of this. I can't remember what COVID was at the beginning of this year, end of last year, and then we had it with the floods. But despite all that, and this is a big shout out to our amazing project officers in Southwest Sydney and Southeast Sydney, we've almost had full enrolment. So we were aiming for 240 participants. We have all our control arm, 120 participants, and we have most of our intervention arm with 105. And so we have our hubs at Miller for the Southwest Sydney and Rockdale for the Southeast Sydney side. And if we look at the Rockdale side, 53 of the 62 women recruited have given birth and been connected into the hub, which has had some interesting workflow issues for the child and family health nurse we've learned about. And 14 of the 43 women in the intervention arm have given birth and connected to the hub in Southwest Sydney so far. And this program will go on until the end of next year. Next slide. Really key to this, though, has been one of the barriers and the facilitators recognised by the service providers in actually implementing integrated hubs. We all think integrated hubs are a pretty good idea, but how do you actually make them happen? And this has been a sub-study that an honours student, Mevney, has done for us and just submitted. So she's done with Michael Hodgson, implementation lead at UNSW. She's done some really nice semi-structured interviews with service providers, thematically analyse them, and then we've used a consolidated framework for implementation research to look at the main themes. And really hats off to Michael and Medley as they have done all this work. Next slide, I'm going to share this. So the first theme is really the complexity of needs that migrant refugee women have. And so one of the barriers is sometimes service providers can feel a bit overwhelmed by the complexity of the needs. It's a bit more than a child and family health check around developmental need. We're finding that migrant and refugee women pretty early on, around 6 to 8 weeks, are showing a clear preference to GP care if the GP is speaking their language. A language barrier clearly is an issue. We're also finding migrant refugee women aren't really wanting to use interpreters, which is really interesting. And there's some limited health literacy and even understanding what a child and family health service does. But the enablers have been being able, by having child and family health nurses and our team connect early, we've been able to provide continuity of care. All the diverse services that are around for families is really helpful, making sure your care is family centred and culturally responsive, and just keeping engagement. And that continuity of care with the same child and family health nurse at each hub site has been key. Next, please. The next one is what's a hub? There's a lot of people saying lots of different concepts of a hub, but we're not that clear. We have developed a logic model that's been published in our protocol paper, but it is actually a barrier because what means a hub for one person means something quite different. A hub is not co-location. You have to have integrated services. There are actually some real difficulties in collaboration made by people's current business rules and limitations in resources and the way funding is provided, particularly for the NGO teams, but also in terms of child and family health nursing staff. Thanks, James. But enablers are making sure that you're communicating a lot and that you have sustained partnerships that are documented. And vital is the role of a hub or service coordinator. At some point, one of the services involved has to have a nominated position that actually sees this hub through and manages the hub. Next slide, please. And I can't read my heading for my theme, but essentially, sorry, but I'm just noting, it's okay. I'll guess. I can't quite remember what that one is, but I think, oh, it's sustainability. Thank you very much. So one of the issues around sustainability, well, clearly funding and staffing, but what has been helpful is the first 2,000 days policy, having our leadership engagement and working with the community. Next slide, please. What's been really nice as part of our role is we're doing implementation workshops and handovers. We're already working with a number of other districts around this. And Michael has put together a fantastic beginning of a hub orientation pack. And so these are just the key components from this pack that are informing our work. The first is don't start a hub unless you've got buy-in. You've really got from the beginning to have a key goal and a key vision and shared commitment. You have to have established partnerships, and that might be a partnership agreement, it might be an MOU. You need to actually have clear ways you're connecting and supporting. So you need to actually document your navigation pathways. You need to have the right people in your hub. It can vary depending on context, but you just need to make sure you've got the right ingredients. And it's an ongoing iterative process. Really, you need to, things change, services change. So you need to have ongoing integration activities that are really well supported by a strong governance structure, both at the leadership and at the operational level, with shared training and evaluation between services. And at all times, keeping the community front and centre in mind. Next slide, please. I just want to thank the first 2,000 Days Care Connect team. This has been funded, as we've said, by the New South Wales Translational Research Grant Scheme. It came from tiny bits of money previously, but what's been amazing is we've had leverage from this grant for $3.3 million in funding and have had a number of publications across. I want to acknowledge Tanya Rhymes, my partner in crime, who's the implementation lead from South East Sydney as well, and all the LHDs that work with us, South East, Northern, South West, Ministry of Health are actively involved, as are the ACI, and I want to thank all my research and implementation partners as well. Thanks. Over to you, Sharky.
Hello all. Thank you. That was a great introduction to our theme, which is the equity-focused hub, right? So I'm talking about the other major issue that we were tackling in our particular theme, which was really improving pathways for Aboriginal children and families living in southwestern Sydney. This really has been a labour of love for the last 3 years over COVID. So I acknowledge all the fellow researchers and really practitioners who have contributed to this, and clearly the lead of Dr. Anne Piper, who is in charge of these partnerships. So obviously I will start with an acknowledgement of the traditional owners of this land that we are meeting on, and I'll pay my respects to elders past, present and emerging, and anyone who's listening in on this talk. Everyone knows this, I think you've heard this many times today, that it's a really large, rapidly growing population. We know about our culturally diverse population, and of course a significant portion of that culturally diverse population is our First Nations population, and in some pockets of southwestern Sydney they make up over 5% of the child and youth population in the Campbelltown region. We know that Aboriginal populations experience a high burden of adverse childhood experiences, and that impact on their health and development also persists to long-term outcomes. We also, of course, acknowledge that our First Nations populations have suffered disadvantage as a direct result of the history of colonization and dislocation, and the cultural oppression and subsequent policies, and including forced removal of children. I just want to make the point that the population we see in the urban settlements of Sydney are really that pointy end, multiply dislocated populations, and children and grandchildren of those who have been part of the forced removal of children. In terms of Aboriginal child health and models, there are integrated models of care for Aboriginal children, but they've generally been discussed in the rural and remote regions. The urban health landscape is much more complex because we have so many different entry points and so many different providers of care. So these models of care are often designed in needy but rural and remote places. From southwestern Sydney, we know from the research that we have done ourselves and our colleagues in Campbelltown that urban Aboriginal children were found to be developmentally vulnerable compared to their non-Aboriginal counterparts, and worryingly, the developmental trajectory worsened over time. So this is local information we have access to. Current service provision in southwestern Sydney, I'm really talking about the publicly funded services. So southwestern Sydney has already invested lots of resources and expertise, and they've really put a lot of effort within the primary and community directorate. They've put a lot of effort into the 0 to 5 year space. There are existing high quality services and initiatives, and also research projects between Southwestern Sydney LHD and our partner Indigenous organisations. We also have, we boast of a very good district-wide home visiting program, targeted home visiting program for Aboriginal families with criteria based on vulnerabilities. But when you think about the children we deal with, there are too many Aboriginal children falling through gaps of too many pathways and initiatives. It's actually not a lack of access, but too much access to the wrong sorts of things, and poor communication, poor coordination, lots of duplication and lack of follow through. Yep. So our aims were to develop culturally appropriate and enhanced trauma-informed pediatric pathways in the community. So I want to make it very clear, publicly funded in the community for Aboriginal children in southwestern Sydney, building on existing public health programs and trying very hard not to duplicate what already exists. So the first part was developing these pathways and program and clinics, and then evaluate the outputs from these new clinical services, then determine how culturally responsive and trauma-informed our services are using a modified version of an existing cultural audit tool, which I'll talk to you about, and we're really proud of that. And finally, identify gaps in service provision that can be responded to with appropriate service enhancement. Next. So what we've done is developed a really rich network of clinical services, community pediatric clinical services, and the locations are where families, First Nations families would feel comfortable and safe and supported by staff. So the sites we have are the Early Learning Centre or preschool run by the Tharawal Aboriginal Corporation in Minto, Warren, Gundagara Health Service here, a local general practice, Kari, which we've had a long standing partnership with, but we've enhanced the clinics we provide there, and also 2 Aboriginal community health centres, one in Miller and one in BestSTART. Then we audited, as I said, what we've done, what have we seen, how have these clinics grown. We just used very simple outcome measures, what are the issues identified, what were the follow-up and all of that stuff. And we really compared occasions of service from when it started in 2018 to 2021. Sorry, that's an update. And of course, we used the cultural audit tool. This tool is something that is completely local to Southwestern Sydney Local Health District. And I'm really proud to say that we worked with wonderful Karen Beetson, who had already developed this from another tool. And so we modified it for child and family health within Southwestern Sydney. And then based on a cultural audit tool, we also used it for open-ended group discussions, and we ran yarning circles. And then we tried to triangulate the findings from what we measured and what we found from our audit tool and our yarning circles. Next. So this is the first one. Really, I'm just giving you very bold figures. And the only things I want you to look at is how it's grown from 2018, when our first pediatrician was employed, through to 2021. You can see a dramatic increase. This is through COVID years. And you can also see the other thing that's increased, that a significant proportion of who we're seeing now is reviews. The other thing is there's an even spread of ages, but an increasing referral base in the school age group. And the reasons for referral are behavioral, developmental, learning difficulties, psychosocial concerns. And, you know, we did the appropriate referrals. I'm not going to tell you what we did with our clinic. Move on. The cultural audit tool, we got this filled out by all the services who are responding to our new pathways. We got about 16 clinicians responding, and admin people, actually. And I think this is the first good news story. A lot of ticks for what we were delivering. Next, in terms of cultural sensitivity. And we had, of course, modified this tool to include a whole range of questions on trauma-informed practice. And again, I think we got a tick on the whole for what we're doing. Next slide. And then our yarning circles. These were, of course, a bit messy to run and didn't run according to plan. But what we found was most locations offer cultural support, great, tick. And the staff were knowledgeable about identifying trauma, tick. But all the others are buts, right? There was a real need for more health worker support, in fact, and Aboriginal health workers to support our clinics. There was a real feeling that these services should be Aboriginal-led, and we agree with that. We know that families went elsewhere. We know that there's confusion, and again, it's about the support we get in our services to deliver what we want to deliver. And we also recognize that there are quite a few families who are identified as First Nations who could seek care in mainstream services. The gaps were clearly the first one, need for an Aboriginal health worker to support our clinics. We know that the existing programs within child and family focus on the 0 to 5 age group. We know there's a big push for the first 2,000 days, but there are increasing numbers of referrals for school age children. This is where children are really failing. And they're unable to access services elsewhere. There's a huge unmet need for case management and coordination of services. There's a significant increase in children and families needing ongoing and long-term review. And we know that Aboriginal families do like continuity, and they do like coming back to a trusted service. And many of the issues that we identified in our audits about the kids we saw were really related to issues within the family. So family disruption, intergenerational trauma, for which there are very inadequate services that we're currently providing. So my concluding remarks are, there's a significant increase in referrals and appointments offered. So therefore, there's a clear need for this service. And so that's, I think, a big good news story. We are providing something that is needed, and people are responding to that. The other big tick, of course, is this is the first use of a cultural audit tool for child, youth, and family services in the community. And this is really something that needs to be replicated and used by other services. We are happy that our services are trauma sensitive and culturally appropriate. But we recognize that there's a demonstrable need for developmental, behavioural and learning support for Aboriginal children in Southwestern Sydney that we're not really able to support. There's clearly a need for more Aboriginal health worker support. And I'd like to announce that we finally found and employed a full-time Aboriginal health worker for our pathways, which is great. And of course, the final bit is the established services and pathways need sustainability. And of course, that's always in the laps of the funders. Thank you.
Thank you very much indeed, Sue and Shanti, for covering that. Now we are done with the themes, and the next two are our platforms. One is the data platform. We call it a BestSTART Data Observatory, which we are very, very grateful to Professor Paul Middleton and his CETI platform to come and integrate with our vision to develop this BestSTART Data Observatory, which is last 10 years of kids born in Southwest Sydney. It's about 10 to 11,000 births a year. So we're talking about more than 100,000 kids in that data platform. So the opportunities for future work based on the platform is enormous. And I initially welcome Professor Paul Middleton and Dr. Frank to come and talk to us about that bigger picture platform. And then Professor Jalaludin will take us through the BestSTART Data Observatory and a glimpse of the possibilities through a small data related work that Jahid and James will provide.
Okay, thank you, Valsa, and thank you to the South Western Sydney for inviting me to talk this morning. I'd like to just spend 5 minutes talking about CEDRIC, our comprehensive epidemiological data set for research, innovation, and collaboration. So this is the patient journey. You can see somebody who gets sick, comes to the hospital by ambulance, comes to the emergency department, is resuscitated, investigated, and then given definitive treatment. And then we hope sent home to be cared for at home and in the community. But in every one of these instances, in every one of these settings, there is data, of course, and data usually that's relatively unused outside the setting itself. And that's because health has evolved in silos, essentially, and that's unavoidable, but it means also that the data involved in all of these different silos stays in the silos as well. It's not a new problem, of course, and most healthcare data has evolved in separate domains. And the EMR, which now, of course, is ubiquitous, has exponentially increased the amount of data that's produced and that we could potentially use. This isn't going to change or pause, of course, but it's going to rapidly become a larger issue. Another thing that we need to think about in here is big data, which people talk about all the time. But in actual fact, I think it looks a little bit like this. This is the tsunami of big data that's coming towards us. And this is not only because of the EMR, but also because of electronic medication charts, fluid and infusion charts, and devices that are electronic. Monitoring systems, ECGs, pulse oximetry, blood pressure, all of which is automated and potentially screenable into databases. A lot of work's done on imaging, particularly in the realm of artificial intelligence, and we use, obviously, not only X-rays, but CTs, MRIs, and increasingly echocardiograms. The pandemic has accelerated the growth in virtual care as well. And pulse oximetry, for instance, has been a ubiquitous tool in the community, trying to actually keep an eye on people with COVID-19 in the longer term. And one of the things that's really coming rapidly towards us is sensors, Internet of Things, wearable devices, which are going to be used in all sorts of settings. And here you can just see an illustration of what's going to be happening in terms of edge and cloud development. Now, this is actually the amount of data in the world from 2010 to now from Statista. And that actually translates to, at the moment in 2022, 97 zettabytes of data. I'll just, that little thing is there to show you that a zettabyte is 1 billion terabytes. Now, the data is suggested that by 2025, there will be 180 zettabytes, which means in 3 years, we're going to double the amount of data available in the world. That's equivalent to 180 billion 2-hour movies, or 1.1 quadrillion books. What's interesting as well, though, of course, this is all the data in the world, but health data actually represents 30% of that, and that proportion is growing all the time. So data about our patients and about the system that we work in is actually going to, if we're not careful, overwhelm us. And here you can just see the sort of settings where data comes from. In the top left, you can see hospital and acute care data. But then there's primary and community care data, which is used to a varying degree. There's ambulance and pre-hospital care data. We have the third largest ambulance service in the world in New South Wales, and we don't actually automatically link to their electronic data in any way at the moment. And then increasingly patient-reported measures and a stream of data from patients actually in the community is going to become important. Now, the pandemic, of course, has accelerated all of this. And you can see here just from the middle of September that 608 million cases, 6.5 million deaths across the world. And this is just some slides showing the confirmed cases and the deaths per million people, and just showing that this is something that's really not going to go away. And in Australia, we've still got substantial people getting COVID and new variants coming through all the time. This just means for us that the pandemic is going to be driving not only healthcare, but also the data associated with it. So where is health now? This is important because health has a number of different data repositories. In the middle of all of this, you can see the Cerner electronic medical record. And then around the outside are all these different databases that are maintained by different groups, whether they're operational and official, or whether they are somewhat less official and used for clinical purposes only. They're all silos of data, which most of the time are not connected to each other. Cerner is a monolithic data structure, and that means because of that monolith, other clinicians have had to develop their own data repositories all over the place, and they may be as sophisticated as a high-end database, they may be an Excel spreadsheet, and data's in all of these places and inaccessible to lots of other people. So CEDRIC, as you can see, comprehensive epidemiological data set for research, innovation, and collaboration. This is what it looks like at the moment. You can see the various parts of Cerner in there, aspirationally to some degree. Coronary care and intensive care, we're working with them to link their data to ours as well. And you can see that we're using, these are all big data tools such as Elasticsearch and Docker and Kubernetes, for those that know what I'm talking about. These are tools that are used to, which are state-of-the-art database tools. And CEDRIC has all the data from South West and Sydney emergency departments linked to inpatient data, to pathology, radiology ordering at the moment, although that's going to change, trauma, cardiology, and various other databases. The data linkage is automated. We use machine learning for pattern recognition, and we have a number of projects using AI in different forms for the studies at the moment. And it currently holds approximately 14 million patient presentations from South West and Sydney. Our plan is also to develop a number of data repositories of databases for our colleagues for clinical specialties all over the LHD. And these will be, they will replace old legacy databases. They will have, or they will deliver the best clinical quality, and they will also have standardized governance. And will link them automatically to CEDRIC, so data from all of our patients could be actually linked together and used for research and clinical care. And this again is automated with metadata and machine learning. Coming towards the conclusion of this, we're also going to be putting in place what we're linking to, we hope, some operational databases. Things like the patient flow portal, health roster, and StaffLink will enable us to actually build our agent-based models of the health system, the emergency department, the hospital, and actually run digital twins of complex adaptive system models and work out how the system works and what it would be like if we did things differently. All in all, that gives us a data fabric where data can be left in place, but can be actually linked and used on a live basis. So it'll deliver that data fabric. There will be multiple databases with robust governance. There will be fit for purpose design, depending on what people need for clinical care and research. And then, as I said, all the data remains in situ and linked by machine learning. We're actually working with Western Sydney Uni cybersecurity to make sure we've got the highest possible level of privacy and security. Thank you very much.
Thanks, Rosa, for the introduction of the observation instance for the introduction of the setting. So based on the Based on the Cedrics as the data support and the platform support, and the data observatory project, we set up the core structure of this database to include like more than 10 years of the babies and their mothers' information. And the journey of starting to set up the structure is actually begin from the mother identification, from the delivery and their bookings and their tests of the results within the EMR system. So with the mother's information, we can find the baby's information, and we can also link by the same linkage of supported by Cedric, we can link back to their every mother and their baby's presentation, like either an ED presentation or inpatient presentation or any outpatient presentation that create those delivery information and routine information and further neonatal information and child health information as well. And for now, the linkage has been finished, has been like done in the progress in the antenatal relating part, postnatal relating part, and neonatal relating part. The further extension via this linkage can be also extended to diagnosis, SurgNet, as mentioned by Paul, and medications, radiology, pathology, all these results from the EMR system, and also some further forms that relating to child and family health and youth health. So with this structure, we are able to answer a lot of the research questions, such as the following two projects. The first one we mentioned as well in the previous presentation is about the COVID trend, which is trying to explore the impact of the COVID in the adult and children presentation. For this project, we supported a 6 years plus retrospective data set according to some criteria. And for the second different project, which is the FDCC project, which we offer a data support for a weekly patient list for midwife to do further screening to find out the proper or the potential participants for this project specifically. And for this project, we include some antenatal booking and delivery information. So that's two of the good example for this type of obstetric support. Thank you.
I'm going to talk about the data observatory, which is out of BestSTART. The data observatory is a key pillar of BestSTART, and the idea was that the aim was to provide a platform to support and conduct research to improve outcomes of mothers and their children in Southwest Sydney LHD. And we will do this establishing a mother and child cohort that includes all pregnancies of children in Southwest Sydney LHD since 2009. So which means that we will have an electronic cohort, an electronic birth cohort starting in 2009. So at least up to now that we were 14 years, 12, 13 years of data. And as the years go on, we will add to the data observatory, and so we'll be increasing our sample size. We will link to all the routinely collected electronic health data, hospitalizations, emergency department visits, and also community health service use data. And our plan is also to sort and link external data collections. I mean, these could be survey data, could be data from other registries. For example, there might be the autism registry, and of data from other government agencies, for example, education, child protection, housing, disability. So what we aim to do is to have a comprehensive data set. In this respect, we've been very fortunate to be able to link to Cedric, and Cedric has now provided us with a rather comprehensive linkage, and also in terms of how we download the data, how we store the data safely, and I think that has been very good for us in BestSTART. And to know the current status, we've obtained ethics, and we've started the data flow from EMR to data observatory platform using Cedric. We are currently road testing the data by analyzing some COVID focused research questions. What we hope to do after we've done our own testing over the next perhaps 3 to 6 months, we hope to have streamlined our data collection, our data linkage, and how we download the data for our researchers. One of our aims about trying to facilitate research and also for quality improvement projects. But something important consideration would be the relevance of the project to the aims of BestSTART-SW, the clarity of the aims and objectives, the significance of innovation of the projects, the scientific quality, and also importantly, the capacity of the investigators to successfully complete the project. So the data platform, as part of BestSTART, we are very, very keen to facilitate research and for at all levels, from our junior staff to our more senior staff. But really, the projects have to meet these important considerations. There'll be a process for access to the data, and they just list some of the steps that we thought would be useful. For example, the project team applies to the Data Observatory governance team for access to the data by completing a form, as usual. The project is conditionally approved by the governance team, and once ethics approval is obtained, we will discuss how we can securely download the data. And obviously, they will provide the annual reporting structures so that we can then include them in our annual report, and also to see how the research team is progressing with your research project. So this is a proposed process. Okay, so I've spoken about the Data Observatory, the aims of the Data Observatory, and how we want to facilitate research. So our aim is that we'll assess all the data requests in a timely and transparent manner. We'll provide guidance on ethics approval process to help the research team, but note, we will not be able to write the ethics proposal for the researchers. We'll also provide advice on research methodology, study design, data analysis, and so on. And we hope we'll be able to support data analysis where resources permit. So through these various processes, we have to also build capacity into research within South West Sydney Local Health District. And but more importantly, this is the last slide. It's important for us to hear from you about your needs and how we can facilitate research using the Data Observatory. Thank you.
Thanks, Paul, Yao, and Zhao for giving that brief overview of the observatory and Cedric. And I'm joined with Jahid, and we've been involved in, like Zhao said, pilot testing the data in terms of looking at COVID-related questions. So these are some of the test research questions that we've been looking at. So an exploratory analysis of commonly reported chronic conditions as per the ED discharge diagnosis between January 2016 to March 2022. And we're also looking at impact of COVID and socio-cultural interactions on deliberate self-harm related ED presentations, and also factors associated with extended length of stay. So in terms of the methods, we've got a data set from January 2016 to March 2022. So we've categorized a pre-COVID period as from January 2016 to February 2020, and COVID period from since March 2020. And we've got the 6 public hospital EDs in Southwest Sydney. And in terms of the statistical analysis, we've been looking to do some exploratory analysis of in terms of frequency distributions and age-wise distributions, as well as looking at logistic regression models. So in terms of the ED presentations related to chronic conditions among children and adolescents up to 18 years, In terms of monthly average, mental health had a significant increase compared to other chronic conditions. And in terms of the age-wise distributions as well, among these population compared to adults, we can see that children aged 6 to 12 years and 13 to 17 years had a significant increase in the ED presentations related to mental health as well. And in this study on factors associated with, and deliberate self-harm was one of the most commonly prevalent mental health related ED presentations. And in this study, we looked at factors associated with deliberate self-harm related ED presentations. We had a sample size of about 7,545. And we did an encounter and level analysis given the research question, because to account for different encounters for each person. And we coded deliberate self-harm positive cases as code 1 as 1 and no DSH as 0. And we found that 1 in 3 of all the mental health related ED presentations were deliberate self-harm. And we also found that older age females and COVID period were associated with increased odds of mental health presentations. And also interestingly, we found children from CALD background had low rates. In terms of the factors associated with extended length of stay, we defined extended length of stay as those presenting with more than 4 hours. Next slide, please. And we found that more than half of all mental health related presentations had extended length of stay. And compared to, again, with the regression models, we found older age groups and children from CALD background had higher odds of mental health presentations, extended length of stay. And given access to COVID, perhaps we found that COVID period had decreased odds of length of stay. The last slide, these are the other projects in the pipeline. We're looking at trends in the mental health related presentations and also the social interaction of socio-cultural factors. And we're looking at clinical characteristics and factors influencing walkout of patients from the ED departments, and also some non-COVID questions like antenatal predictors, mental health issues, and interactions of psychosocial adversity associated with perinatal outcomes with the use of this data. Thank you.
Thank you.
Thank you very much indeed for the run through of one of the key pillars, that's the data century, and thank you for the CETRI platform for coming on and talking to us about it as well. Our next one is about capacity building. So that we have got 2 main platforms, which are the data observatory, and the other is how do we engage and how do we build the capacity of the clinicians. So for that theme, we have got 3 presenters. One is Associate Professor Jane Collop, who's also a significant partner through our Peritonic collaborations and also BSW. Associate Professor Raji Jairam, who will be talking about in-house in the inpatient unit within Southwest Sydney LHD, how BestSTART is supporting research there, and a showcase of our next generation of clinicians and medical students, Joanne Joseph, talking about her. So over to you to start.
Thank you, Valsa. So yes, my name is Jane Collop. I'm from the University of New South Wales, which is also Karitani. I work as part of an academic partnership between Karitani and UNSW, really seeking to support clinicians to space of infant and early childhood mental health and perinatal mental health. And today I'm talking about a project that I have been working with a group of clinicians on called Emotional Connection and Contagion, evaluation of an arts-based and biofeedback professional development program for child and family health nurses and midwives. So today I'm speaking on behalf of a team of clinicians, and really Karen Wilcox, the clinical nurse consultant at Karitani, was the heart and the brains behind this project. But I've also been working with Barbara Doran from UTS, who's an academic and artist, and Anne Dadich from Western Sydney University, Suzanne Kalman and Tiana Barrington, clinicians at the residential unit where we're doing the project. And we couldn't have done this without the generous support of our funders. So we wanted to thank the ELDO Clinical Academic Group, and Severe Knowledge Translation Strategic Platform for their seed funding, which has helped us do this project. So the impetus for this project really came from Karen Wilcox, the CNC, who had noticed that at the Karitani residential unit, there was a lot of emotions, a very emotionally laden environment. So those of you who don't know, the residential unit at Karitani is a 4 to 5 day residential program for families with complex early parenting issues. So typically parents present with difficulties with infant and child focused problems, so sleeping, settling, feeding, and early toddler behaviour problems. But really the families present with a range of really complex psychosocial risk factors as well. And a key part of the admission on the Monday is an admission interview that the child and family nurses do with the families, where they talk about presenting problems, but do a really comprehensive psychosocial assessment and depression and mental health and domestic violence screening. So it can be a very intense day on the Monday. You've got a number of families arriving from after travelling across Sydney, being on a wait list for this program with complex problems and family environments. And the nurses do this really in-depth admission, and then they hand over to the afternoon staff in the afternoon who start the intervention. So what Karen really, she really wanted to investigate and think about ways that we can help staff to manage this emotion, the emotional content that they were facing. And really she observed that the emotions were being quite contagious among the staff, both in the handovers, but also in the way that they talked and dealt with each other. And she wondered whether this was having an impact on clinical care and on families. So the objectives of our research really were just to clarify and explore the role of emotions at the Karitani residential unit, but then also to develop and evaluate an intervention, I guess, and a new arts-based professional development program that really aimed to enhance emotional awareness and wellbeing of the child and family health nurses at Karitani, and potentially the quality of clinical care that they were providing. So the project is divided into 2 phases, and it's very much a work in progress. The first phase was, the aim is really to explore the emotions at the residential unit. So we've been conducting interviews with residential unit child and family health nurses and midwives, and with parents. We've also been taking photos of the families on day 1 and day 5 of the admission. And part of the aim of this is we're using some, in a very exploratory fashion, looking at using a face reader to look at changes in facial expression of emotions across the intervention, but also to develop an artwork or an artefact at the end of the project, which is a way that we can commemorate our process and to communicate our findings. As I said, we're in the middle of this project, and so I'm not reporting any of the parent interview data, but you can see on the screen there some snippets from the interviews that we've done with the nurses themselves. So we asked them to describe how they thought the clients might be feeling on their admission day. And you can see there's a lot of big and negative emotions that the parents are coming to the unit with. And then we also asked the nurses themselves how they're feeling during that admission interview and over that first day, and they described it as rush hour, and one nurse even talked about the stress being palpable. We also asked the clinicians to comment on the impact that it had on them to be hearing all of the information from the families in that first day. And you can see the comments there. So one nurse said, heavy. Some of the stuff we hear is really heavy. Sometimes the first time they've disclosed domestic violence also, and it does sometimes affect you. So another nurse said, I've actually got to the point where I don't want to hear people's stories anymore. And then you get to the next day, you've got the multidisciplinary team meeting, you have to tell the story again, and in handover, you're telling the story again. And so it's a lot, really tiring. And we also asked them about their perceptions of emotional contagion. And one nurse said the stress circulates, there's a domino effect. The second phase of the program, which we're just getting into now, is to evaluate our new arts-based professional development program. And the objectives of the program really are to use arts-based methods to help the nurses to enhance their interoception. So that's an increased awareness of their bodily sensations. And there's a lot of evidence to show that this can really improve stress management and help people to become more aware of what's going on in their body and help them to be less able to withstand and have resilience in the face of this really tiring and stressful and emotionally laden work. So just really briefly, the nurses on a Monday, after they've had the clinical admission process and they've done their handover, they have half an hour where they get to go and do arts-based methods, including a body map and artification, we call it. And then also, again, taking facial portraits before and after each session and being able to reflect on what they can see in their own face. Yeah, and we're collecting data pre and post, looking at stress, emotions in the parents, interoceptive awareness, but also qualitative information about how the pet that they found the program. So I look forward to updating you on the progress of this project in the future.
Hello, just checking that you can hear me.
Yes.
Very good. Just sharing my screen. And you can see the screen, the slides. I think you muted, but I just assume that you can see the slides.
Yes, we can.
Yeah, lovely. Thank you. So hello, everybody, and it's such a pleasure to be here amongst a number of different kinds of researchers and clinicians who all, I think the best part is that we're keeping the child and family in the center of all what we do. And that indeed is something that drives us to better our practice, currently and into the future. So what I'm going to talk about, I think fits quite well with Cedric, and we're eagerly anticipating Cedric. It's sort of pre-Cedric, a little bit of a dinosaur way of trawling through quite a lot of data, and as was mentioned earlier, quite a lot of silos to try and break through. So we'll see what we can do. So the link study really was about trying to bridge the gap for these children and adolescents who access the emergency services and leaving the emergency services, what kind of interventions they got in the community and whether that was appropriate or not. And so really I'm speaking on behalf of the link team that consists of a number of people in the audience here as well. So all of you have contributed quite a bit to the study, and also acknowledge the grant received from what is now called as the Perinatal Child and Youth Branch, Mental Health Branch of New South Wales Health. And why did we do this? Because over the years, I think the first graph is the early 2000s, until sort of a couple of years back, the number of presentations to the emergency departments by our children and adolescents for mental health problems has grown significantly. So much so that statewide, we are probably the highest, we have the highest number of young people presenting to our different emergency departments. We have 3 major and 3 minor kind of hospitals within our district, as most of you are aware. And really a lot of these children, when they do present to the ED, have an assessment, have a plan made, and then they're discharged. So the vast majority, over 90%, are discharged into the community. And we sort of don't know, not quite sure, we weren't quite sure as to what happens to these kids. Do they actually receive the follow-up that as intended? But we know that it's sort of something that doesn't always occur. So our study aimed to gain a much clearer understanding of how many are followed up, how many aren't, what are the trends, and once we understand this better, we can then perhaps have a think about how we reshape or redeploy our services, or indeed look at creating appropriate services to cater to those that perhaps may fall through the gaps. So what was our study design? Well, it was looking at data from 2018 to 2021. So the 3.5 years, it just so happened that it also was a good opportunity for us to study some trends pre, during, and post-COVID as well. And during this period, there were over 5,400 presentations. to 3 major hospitals. So we focused on Bankstown, Liverpool, and Campbelltown. And then a retrospective analysis of the electronic medical records, looking for linkages that presented for those that presented to the emergency departments, and subsequently in the 48-hour window following their presentation to the emergency department, were they followed up by our community mental health services. Again, talking about silos, they're all not part of the same data set. So trying to get 3 different data sets from the 3 different sources and trying to match it was not a simple task. And once that kind of matching was done, and again, not all children and families behave appropriately as we expect. So someone that presents at Bankstown may go to Campbelltown for a follow-up, or they may have been living somewhere else and were on their way back from the city and presented to a particular hospital, but their place of residence was elsewhere, and so on and so forth. So the ability for us to connect all of this data is very much dependent on some of the real life variables which we can't always control for, and we perform some regression analysis to sort of predict whether or not they followed up, considering a range of different covariates. And what have we found? Well, the green is Campbelltown Hospital, the blue is Liverpool, and the red is Bankstown. So as you can see, by far, that since 2018, from 2018 to 2022, there is quite a significant, the higher number of kids presenting to the ED in Campbelltown, and especially during the COVID times, this had a significant peak, as was already mentioned. Liverpool had a similar kind of situation. Bankstown, we didn't see a similar peak, which is interesting. And overall, really, I don't want to go through this slide in too much detail, except to say that really, apart from our numbers, which seem to be sort of increasing, 2018 was a high year, but it's been sort of steadily increasing as well since then. And we already had over 900 presentations in the first half of 2021. The bulk of the other data sort of remain remarkably consistent. So what did we find? What we found was quite worrying in the first instance. What we found was that the data analysis indicated that that nearly half were not followed up in the subsequent sort of 48-hour window, and this was very, very significant because that is far more than what we ever anticipated or expected. And 2020, what we found was a significant outlier in the sense that the number of sort of kids not followed up during that period was much higher than any other period. And we wondered whether it was a COVID effect. Also, what we found was that there was a consistent sort of finding that earlier visits to the ED was associated with greater odds of being followed up. The risk of self-harm was associated with the greater odds, which means that kids that had self-harmed seem to have a better chance of being followed up. The younger ones were being also followed up at a higher rate, which was quite reassuring as part of the broad brush data. And females had a higher chance of being followed up as well. So in terms of sort of final conclusions, finishing, that we do recommend that there be far more increased rates of follow-ups for the first time visitors to the ED, and also for males, because they seem to be falling through the cracks a little bit more.
Thank you very much indeed.
Just the last one sentence, Walsa, I'm so sorry, that we are embarking on a second part 2 of this, and thankfully that's not sort of too grim in the sense that we're finding that we'll have to sort of open the files and look at it, that really there were a number of these other reasons as to why these kids may not have been followed up, and it's not as grim. And Chloe, who's one of our registrars, is leading the study. So we'll just watch the space for the next step. Thank you.
We have got the student presentation from Joanne Joseph, and otherwise we will be putting all that together into the video and you can watch it later. But those who want to stay on for Joanne's presentation, please do.
Hi everyone, so my name is Joanne. I'm one of the 5th year medical students and I'll be presenting our research on screening for media use in the ED, our problematic internet behaviors related to young people's mental health and their ED representations. So internet use is currently continuously rising with around 27,000 new internet users every hour and over 4.6 billion active users globally. Similarly, there's been a 13% rise in mental illness in the past decade, with suicide being the leading cause of adolescent death in Australia. So how are these related? While simply using the internet is unlikely to cause mental health issues, excessive internet use has been associated with mental illness. However, current research correlating the two broadly assesses internet through the lens of addiction, measuring frequency, length of time of internet use, and withdrawal symptoms, and fails to capture how time is spent on the internet. As such, someone spending excessive time watching educational videos could score the same as someone gaming every day, despite these behaviors having different extents of concern and therapy. In an attempt to combat such issues, our team developed the EDMIS, or the Emergency Department Media Use Screener, to capture specific online behaviors in a 24-item questionnaire. These behaviors included accessing or posting harm advocating content, cyberbullying, receiving inappropriate unwanted content, and concern over internet use. The tool was designed with a clinical purpose of investigating suicide cluster cases among adolescents in Campbelltown in 2019, believed to have been propagated by the internet. Our research objective was to use the EDMIS to describe patterns of media use and ascertain if it could be associated with mental health or with subsequent presentations to the ED with research questions relating to the same. To do so, we conducted a cross-sectional retrospective study with the EDMIS tool rolled out to patients aged 11 to 25 who presented to the ED with mental health concerns. We also linked the EDMIS to patient medical records to extract demographic data and their background mental health. Since the EDMIS was the first designed as a clinical tool, it was not intended to generate a total score. Hence, we investigated individual EDMIS items. Tetrachoric correlation matrices were constructed to assess the multicollinearity between variables, and items most highly correlated were grouped into clusters. Cluster 1 included 3 items about participants' own actions, such as if they had posted online about suicide, self-harm, or aggression. Cluster 2 about items related to others' actions, such as if they'd been cyberbullied or received unwanted, inappropriate content. Cluster 3 included 2 items about if their family had concern over their internet use or thought it was addictive. And Cluster 4 included 2 items about if they themselves thought that their internet use was problematic. 149 participants met the inclusion criteria, were mostly female and had a mean age of 17.3 years and presented predominantly with suicide or self-harm related concerns and behaviors. Among participants, 80.5% had a mental health issue, of which depression and anxiety were most common. In the interest of time, I'll be presenting the results on our predictors of representing to the ED. So among 149 participants, 58 represented to the ED within 3 months of their initial screen. And overall, we found that having a recorded diagnosis of personality disorder or PTSD were strong independent predictors of readmission, and importantly, were also marginally significant in predicting readmission indirectly through a lack of family concern in cluster 3 and concern over own internet use shown by cluster 4. So how does this compare to current literature? While research advocates that poor emotional support in general increases the likelihood of readmission, especially among individuals with psychiatric diagnosis, literature specific to family concern over the internet use and readmission is lacking. Similarly, the interaction between low family concern over the internet use, readmission, and personality disorders specifically has not been explored previously, highlighting the need for further research to confirm our findings. None of the other EDMIS clusters were predictive of readmission, suggesting more nuanced relationships than those explored here. Without follow-ups, it's difficult to know the rates of false negatives and whether this had an impact on our findings. Hence, implementing screening or reviews at different time points may be valuable in assessing the risk posed by problematic internet behaviors for readmission and in identifying those individuals most at risk. I completed this study as part of my honors project with my supervisors from BestSTART, Tony, Prof. Dollar, and Prof. Ethan, and our goal was to provide clinicians with a better understanding of their patients' behaviors and the internet's underlying influence, hence potentially being a point of acute intervention for risk to others. For example, 6.7% of our participants reported having planned self-harm and suicide with someone else. Furthermore, the EDMIS can be used as a means to facilitate conversations between patients and families, allowing for better matching of intervention and supports alongside implementation of risk mitigating strategies. Our study has reiterated that understanding a participant's risk profile involves exploring their social supports among other attributes. Thank you.
I would like to invite Professor Josephine Chow, the Director of Strategies and Partnerships, to say a few words and conclude the session.
Yeah, thank you, Welsa. Well done. I think we can see the passionate part of everybody. And in my role as the Director of Strategic Partnership and Deputy Director of Research for the LHD, it is my absolute pleasure to thank you for all of you attending the online Health Beyond Research Innovation Seminar today. Knowing that 2.5 hours is too much to ask for the busy schedule for everybody, but really greatly appreciated. We have consistent, I've been keeping an eye on that. We can consistent between 80 to 100 login for today's seminar. Fantastic. All right. Today, we're not only celebrating the academic unit and also the passionate researcher. We are also witnessing the excellent achievement of the Southwestern Sydney academic unit, the BestSTART. The BestSTART is one of the academic unit of one of the 10 academic unit fully funded by the Southwestern Sydney HD for duration of period, and then most of them actually like BestSTART. We are absolutely really confident that they will be sustainable with the amount of funding grant that Welsa and the team actually achieved today. Thank you for the leadership for Welsa, Professor Ethan. Thank you for the excellent presentations, Associate Professor Elizabeth Murphy, and the large group of speakers. I hope you all enjoy the presentation, and then we watch beyond what they can actually do from this group. As what Professor Bouquet in his opening speech, it is really exciting to hear finally the switch is finally switch on. The Southwest Sydney Institute for Translational Child Health Research, I need to get it right, switch. I look forward to this multidisciplinary approach to address health development for the child health research, not just the early stage of children, but towards the youth as well. I would also like to acknowledge all the behind the scene works from the Research Directorate team and the Ingham Institute team, Tiga, Anna Marie, Rachel, and Morel. Excellent job, ladies, as usual. And we will waiting for the next event, which will be hosted by the Fairfield team on the 9th of November. And all the session today, you won't miss anything because we're going to record it and then try to encourage you to facilitate that with your team to make sure that information is shared around. Once again, thank you for making the time to join us today and celebrate the great achievement and success of this particular BestSTART academic unit. Take care.
Again, everyone, for joining us for the showcase this morning. And in case you have missed a session or one here or there, or you want to capture the whole thing again and digest it a bit more, please refer to the video when it's available. And we look forward to brighter future with us switching on the SWITCH program, which is the Southwest Sydney Institute for Translation Child Health Research. And we've already established the basic pillars in the premise, And hopefully that will stand us in good stead as we go forward with child health research in this community. Thank you again for joining.